We have David Reich-Hale here from Newsday on the phone. Hello, David.
Hey, how are you? It's 54 degrees. Why am I talking to you?
I know, right?
I haven't been outside for about 8 hours. So
oh, really? Okay.
This is news to me. So yeah, I cannot wait to at least enjoy about 30 minutes of sunshine.
Yeah, and it's gonna go right down through the floor again. I heard it.
Yeah, that's what I heard too.
Yeah, so get out there quick. Wow. Get out there quick.
Yeah, exactly. All right, bye.
Right. Okay, well, let's get a little business in first. Sure. This is quite a story you got here. The hospitals feeling the financial squeeze look to keep patients healthier.
Yes.
That's in the business section. Now, is this in the paper this Friday or Saturday?
It'll be in the Sunday paper. So if you're picking up the Sunday Newsday, it'll be a 3-page spread in the business section of the Sunday paper.
Okay. Well, all right. Well, go ahead. Tell us what's going on here.
Well, Medicare and Medicaid have often paid less than private insurers for the cost of care, for the service, right? So if you're a Medicare patient or you're a Medicaid patient and a doctor sees you and then another patient comes in and that patient has regular insurance, chances are they're going to get paid more for helping the person with the regular insurance. Right. Now, the doctor generally does not go. The doctor's going to see all the patients, just like the hospitals are going to see all the patients. But from an economic standpoint, the big difference is this: about 35% of all people have either Medicare or Medicaid. Medicare being for people who are over 65, Medicaid for people who are in a certain economic bracket, right? Lower income folk and that sort of thing. Mm-hmm. But when you look at who the hospital sees, the hospital, about maybe more than 60% of who the hospital sees are Medicare and Medicaid patients. Why is that? Well, number one, people who are older often get rushed to the hospital more often or have to go to the hospital more often. Number two, people who are less fortunate economically are often rushed to the hospital more often because they don't have the wherewithal to live as healthy a life. Or if they don't have insurance, sometimes they'll just go directly to the emergency room, which is highly costly for the health systems, right? So from the hospital point of view, they are seeing far higher percentage of patients that are on Medicare or Medicaid compared to the populace at whole. And that's created a strain on their system.
Right. So that's pretty much it in a nutshell, right? And that's what they're saying.
Well, yeah, and also there were a lot of changes in the way New York State has doled out the payments from Medicaid, and also the federal government handles or oversees Medicare. They have put sort of pressures on the health system saying, look, if you don't take care of somebody properly, or you don't get them to take care of themselves, if they come back to the hospital with the same problem, we're not going to pay you as much. In fact, there's some situations they'll pay very little. Wow. So imagine then the health systems are now being enticed to help the patient take care of themselves so they don't end up in the hospital. And that's a big part of the story too. So it's interesting, right? It's not as simple as it used to be, which is hospital sees patient, hospital gets paid, hospital sends patient home. If patient comes back, great.
Right.
All right, welcome back here.
But there's a few issues here. Do you think, it looks to me like this is just an algorithm that they set up in order to deal with some financial situation. You can't automatically blame a hospital when someone comes back for what they would view as the same problem. But that's what they're saying they're going to do.
Well, yeah, that's what they're doing, and they've been doing that. But the reason for it, and yeah, you can't necessarily look. If I come to your hospital, and you're the doctor, and you say to me, David, take your blood pressure medicine. And I say, okay, sorry, I'll take my blood pressure medicine, but I don't have any on me right now. Can you give me 3 or 4 so I can get through the next 3 or 4 days? And I give you 3 or 4, or if I can.
Right.
And then I take the 3 or 4, and then I feel like I'm going to wait another week or two to pick up my medicine again because I'm going to wait another week or two. It might be because I don't feel like picking up the medicine. It might be because I can't afford the medicine.
Right.
It might be any number of reasons, right? But that's neither here nor there for this. And because I don't take the medicine, I end up back in the hospital again.
Okay, well, wait a minute.
So the way, just to wrap this thought up, the way the way the state is looking at this, and the way the federal government looks at it, is set up a system so you know for sure that these folks are taking their medicine. So they have care coordinators in place. They have other systems in place where they're checking in with these patients to make sure that they get their medicine.
But isn't it still an assumption that you went back to the hospital because you didn't take your medicine?
Oh, sure. It could be any number of reasons.
I mean,
it could be any number of reasons, right?
Yeah.
So the idea to keep people healthy is one that they believe will cut down on the returns. Mm-hmm. Back in 2014, New York created this pretty aggressive model where they said we want to see the percentage of readmitted folks drop something like, I think it was 20%, and it's 25%. Yeah. Mm-hmm. So the exact wording here is health systems will be rewarded if they're able to lower the number of avoidable hospitalizations, which include being readmitted for chronic conditions, by 25% by March of 2020. Mm. So we still have a little while to go, but most health systems say that they're doing okay on this.
Right. But there is the jury's still out on whether or not they're going to hit their target at all. Yes, absolutely. But think of how much, from an economic point of view, if you were to get, and this is sort of a fun thing to do, take a look at how much an EKG costs at a private doctor's office and how much an EKG costs if you get taken to Long Island Jewish Medical. Oh yeah,
it's insane, the price difference.
Well, you want to compare prices? Walk into 7-Eleven and buy an aspirin, and then go to the hospital and get an aspirin.
Right.
And we're talking about a $25 difference.
Oh yeah, you're talking about how they'll bill you. The Advil will say $42.
Yeah,
right. Whatever. Yeah,
see,
yeah, and
because when a hospital says to me we're feeling the financial squeeze,
you're not feeling sorry for it.
Well, no, I'm really not. I'm really not, because those prices are so inflated.
So one of the reasons why they do that, and
right, I get it, but it's to the point of absurdity. When are we going to figure this out?
Well, isn't the whole system can be considered that to a certain extent, right? I mean, I've written about dentists, I've written about various doctors, and some of the doctors that they have a certain rate that they bill, knowing that they're going to get 30% of it.
Right.
So, and the insurers know this as well.
Now, do you think that this nightmare that you wrote about, which I mean, it really is, will this? Because, now we've got that young congresswoman from the Bronx who's making all a hubbub about, universal health care. Will an issue like this spur to get people to think that maybe that's not such a bad idea? Because if this kind of thing just goes to its logical conclusion, either hospitals are going out of business and nobody will have a place to get better.
So it's a very difficult question to answer, right? Yes. Because the winds of political change seem, at least in this day and age.
I apologize for that.
No, that's okay. Well, I don't think it's your fault that this is the way it is, right?
Okay.
But the winds of change in politics seem to shift every 35 seconds, 36 seconds, right? Yeah. You never know what people are thinking, but we are kind of at the point now where the Democrats are running a whole lot of people to run in 2020, right? Mm-hmm. Every one of them is going to try to outflank the other to look like they are the best for the base of the party. Right. So you're going to hear a lot about, well, now it's called Medicare for all or Medicaid for all, right? That's the new lingo, but it's really the same thing that we heard in the 80s and in the 90s, and then we heard from at that point Senator Obama. It's not a new issue,
no,
and so I don't know that once you get to the general election, there's an appetite for this. I don't know. I do know that that if you were to push that sort of thing, the hospitals would be completely against it, because imagine now they're saying, hey, we're getting paid not close to what it's costing us for the cost of care by the group of people who are using government-funded health care.
Right.
What happens if we throw everybody on it? From an economic point of view, the hospitals see it as a non-starter.
Right.
That's just one piece of it.
Right.
And so I don't know.
So, I mean, it all boils down again to the almighty dollar.
Oh, sure.
Yeah. Oh, sure.
Sure.
Right.
Yeah.
Yeah.
I mean, it does, but it does elsewhere too, right? I mean, we talk about
I get that.
free health care in Canada.
I get
it's
that.
It's not free in Canada. You're paying for it there too. You're paying for it differently.
Right.
And
I would be curious though what the hospitals, what their numbers actually are as far as what they feel they should charge a patient.
So the one thing about hospitals that makes it sort of difficult to be able to say, hey, look, this is where they are on profit, right? Is they are all in fact nonprofits.
Right.
And because they're nonprofits, they reinvest the money, is how they put it, right?
Mm-hmm.
They spend the money on whatever it is they decide to spend the money on. That could be research and development. That could be new technology.
Mm-hmm.
That could be staff.
Right.
And that staff could be anything from more doctors and nurses to more media relations people, right? I mean, who knows?
Right.
Who knows, right? Or more lobbyists. It could be almost anything.
Right.
But they do spend the money, and they end up with a margin of about 1% or less than that. So you can look at it two ways. You can look at it. I'll give you both ways you could look at it, and I'm not sure which way is correct. But one of them is we have Sinai Health System, for instance. They're an $8 billion health system. Their margin is say less than 1%. So if we say their margin is $80 million, they say that they had $150 million in uncompensated care. That means their uncompensated care coverage, care they did not pay for, is twice what their operating margin was. Now, of course, that sounds drastic. On the other hand, they didn't have to spend everything they had to spend if they were answering to shareholders.
Right.
I'm not saying that it would be better if they were answering to shareholders. It could probably be a lot worse.
Yeah.
But my point is, it's very difficult to make complete financial sense out of this.
Yeah, it does. Oh, there were just so many things. I mean, see, I don't know. I'm stunned here. I do think that, I've heard this statistic that out of 58 industrialized nations in the world, we're the only ones that don't have universal health care for their populations.
Well, we have it for, and it's not universal, but we do have government-funded health care for quite a few people, but not for everybody or even close to everybody.
Right. Well, that idea was the safety net. That wasn't
right.
Right. Okay.
Of course. And then if you ask people, do you want to give up your health care? And we wrote about this, or I wrote about this in the last few weeks. Mm-hmm. Is look at some of the policies that are coming out now. Right. You have deductibles that are making it a lot more difficult for people to pay their bills. Mm-hmm. So some people are paying $1,000 a paycheck or close to it out of their just for their health insurance, and then they have another $2,500 to $5,000 in deductibles.
Right?
Who can afford that?
Well, I don't consider that insurance.
No, it's barely insurance. Right. But there are other people. I mean, New York City teachers and a lot of other organizations. Some of them are union based, which is interesting. They get insurance where they have zero deductibles. They're paying $25 copays to go to the doctor,
right.
$50 to $150 for copays, depending on surgeries and that sort of thing.
Right.
That kind of person doesn't want to give up their health care.
Oh no.
So there's, and of course, we haven't even gotten into the pharmaceutical crisis, which can be extreme.
Right.
Yeah.
Well, I think, two interesting things. One of them here is that us in the United States, our health care has traditionally been tied to our work, which has been a way that corporations can twist your arm, and people aren't so ready to get up and complain about working conditions and some of the things they have to live through in order to make that salary because they're afraid of losing their health care. To me, I think one of the greatest benefits of universal health care would be that would not continue anymore. Your health care would come from a place totally differently than your workplace.
It could,
right.
but are they? Well, how would you feel about that if they took another? And I'm making up this number.
Yep.
But if they were going to take away another 7 to 10% of your paycheck, and the other question, because it's going to be taxed, somebody has to pay for it. And the other part of it is, let me ask you this: do you want the state to run this? Do you want it to be run completely from one spot in the federal government? Because if it's the state, we have billions of dollars of. Apparently, we have a $2.3 billion gap now.
Okay.
And of course, we already know where the federal government is.
Well, let me rephrase your question when it's handed to me, because now you're asking me, do I want a profit-centered capitalist or the government to run my health care? And from my point of view, I could be fairly screwed either way.
Well, yeah.
Why would it matter to me? At the very least, my government is not going to appear as though profit is their motive. I've watched healthcare, and they keep calling it the health industry. And I say, you know what? You guys ought to be more about health and less about industry, because all I hear you complaining about is how much money you're not making, as compared to who?
Yes, and look, the hospitals, when we talk about the squeeze that they're facing and taking care of certain people, let's be clear, the top health systems in the New York area are doing pretty well. Now, the ones that handle mostly the groups that we're talking about, or actually run by the government, they're actually far worse off. That's something to think about too. I mean, NUMC has been financially wrecked, right? They've asked Northwell to help them,
right?
So. Again, I'm not fighting you on the idea of government getting more involved in healthcare. I'm just saying it's very, very unclear that they could do it.
Yeah. Well, it's not clear that anybody can do it.
Sure.
From my point of view, I mean, I don't understand. Well, I do understand, but I don't like the idea, and I don't think that healthcare, education, and there may be one other thing, and I can't think of right off now, should be profit centers. I just don't think they should be. When people are sick, they should get health care.
Well, and they do. But it's not. But it's not equal health care, and that's what this story also is about. And that's why the state, by the way, put in all these incentives for the programs to be put in place, because it forces the hospitals or the health systems to take care of people who otherwise probably wouldn't get that kind of care.
See, I was going to ask you that question. I'm sorry to cut you off. I was going to ask you that question originally. Does a doctor know when he's taking care of a patient how they're financed?
How they're financed? Usually, I mean, that's a good question. I think they have an idea of the greater pie, right? I don't know if they know every time they walk in to see a patient.
Right, because my question would be, if you do know that instant, are the Medicaid and Medicare patients getting the same treatment that a person in a private?
Every doctor I've ever spoken to about that would tell you the same thing.
Well,
yes.
Yeah.
Which is yes. If they're taking Medicare patients or Medicaid patients, they're not going to treat them worse.
Right.
That's an ethical thing for them.
Well,
but that's a specific doctor, right? Doctors are caught up in the same system that we're caught up in.
Right. I think patients would feel happier if they were anonymous as far as how this is getting paid for.
Well, the doctors might not even be involved at all in that stuff. I mean, when you check into the doctor never looks at any of that stuff when she's talking to you, right? They're not. Yeah. They're not the ones, and they didn't create this system either. But if I could quickly just say one thing is when one of the big pushes is having community health workers. Now, Northwell is one of the ones that are training them, but Catholic Health Services and Stony Brook and a lot of the other ones are doing some similar things. But the way I'll describe this one to you is one I think you'll appreciate. So Northwell trains these folks. Right. They then get positioned into doctors' offices. I talked to one gentleman who he's now working at an islip pediatrician's office.
Right.
His job is to link up with patients who don't have the economic wherewithal to take care of everything that they need to take care of.
Right.
And he is an expert on knowing how to get various benefits.
Right.
So now imagine a pediatrician's office is helping you figure out how to get various SNAP benefits, which are nutritional benefits, right? Get Social Security benefits,
right,
if you're entitled to them, and other kind of benefits. That's not something that would have probably happened all that often years ago.
That's true. And you think that's in direct response to this pressure from the government?
It's 100%.
Okay.
Because of
right.
Yeah, DSRIP is the acronym for it. Yeah. Oh yeah. The state wants the health systems to be tied to the outcomes that they are getting.
Yeah.
It's this whole quote unquote population health push that all health systems are supposed to be going toward, and mostly are.
Yeah. Well, I mean, if they result in better health, okay, but I reserve judgment only because I'd like to see it go for a little while.
Absolutely.
Because I can see something like this, too, evolving into the medical mafia. And you didn't take your pills. We told you to. How many times? Or, you know what I'm saying?
Yes. But who's going to get punished for that? The health system. So the health system's not going to say, well, we told him for her to take their pills, so give us our money. The government's going to, the payer's saying, no, we told you to figure out a system in which you know that they have to take their pills.
Right.
So now what they're doing is they're doing check-ins with patients.
Now this is
So if any of these systems and some of them, like Catholic Health Services, I think was one that has a system in place where they're able to say, okay, here are some of the patients that we believe are high risk. Let's reach out to them. Let's see if we can get them participating in a program where we have nurses and we have social workers and we have other
paid positions,
experts, right? Who are but their job is to make sure that these patients are staying on
towing
course.
the line.
So they found about 2,000 patients who have been identified as high risk, and about 60% of them are actively participating in their programs and getting them to where they're healthier, so they're not being rushed to one of those hospitals.
Okay.
So in the end, yes, I get it. There's profit in that. They're not going back to the hospital, and that's a good thing because that's costly.
Yeah.
But at the same time, if it's making people healthy,
or
healthier, that's a good thing too.
Right, it's a win-win. Yeah, you're right.
That's a win. That's a win-win.
Okay, so far.
I'm not telling you that this is.
I know.
Perfect.
I know you're not. Yeah.
But the one thing people used to think, which was, oh yeah, hospitals don't care. They'll send you home, and if you come back, they'll just bang you again for another bill. Mm-hmm. All right? Oh, that's what they're trying to put a stop to.
Yeah. Well, it's nice to think that your doctor actually cares about your health rather than,
right.
I fixed it next,
Right. Well, one day, take a look at your hospital or take a look online. It's another piece that I wrote with a couple of colleagues about how you can look at what they charge at the various hospitals.
Yeah.
That's a lot of fun. I was like, wow, it's $16,400 at this hospital, but it's $12,500 at the other, and I don't know if anybody could even answer why.
Right.
It's quite curious.
Well, I mean, someday I hope we all, cooler heads prevail, and it all boils down to something that serves everyone, and but I don't know.
Well, who knows?
Yeah,
and again, like I said, we didn't even talk about the pharmacy aspect of this and what's happening there, where you have certain costs tied to drugs based on all kinds of backroom deals, and then depending on your healthcare insurance, you can go to some pharmacies but not others. And CVS owns one of the distribution groups. I mean, it's
oh boy,
it's something.
Okay, I want to read
we'll
that.
Talk about that stuff. We'll talk about that some other time.
Yeah, I want to read that story. Yeah. Well, okay. Well, so you keep investigating, and we'll keep bothering you to tell us what's going on.
I love talking to you. So is it 52 degrees yet? Can I still have time to go outside? Or?
Yeah, right. I'll give you a warning. Yes, Yes, it is 52. You better get out there.
All right. Very good.
Thank you very much, David.
Absolutely. Thanks for having me.
We'll talk to you soon.
Okay.
Take care.
All right. Bye-bye.
Yes, and we want to thank David Reich-Hale for calling in and talking to us about his story about hospitals feeling a financial squeeze. He's always full of information. We also want to thank Newsday for letting the reporters call us and talk to us about the stories that they've written.